Hello, I'm Heather Lee Smith, a physician assistant and certified diabetes educator with Wake Med's Maternal Fetal Medicine office in Raleigh, North Carolina, here to discuss pre-existing diabetes in pregnancy. This is part 2 of 2. In the beginning in part 1, we discussed the prevalence, the risk of fetal anomalies and risk to mom. We discussed blood sugar goals and monitoring and preconception counseling. Now we're going to focus on medication management. Before we get there, though, remember treatment of pre-gestational diabetes is fourfold, consisting of a healthy carbohydrate consistent diet of about 175 grams of carbs per day for patients that are pregnant, along with low impact exercise, blood glucose monitoring, either by a blood glucose monitor, a finger stick monitor, or a continuous glucose monitor, of which we discussed in our last session. And then medication if blood sugars are not managed with diet and exercise. And of course, a type 1 diabetic would have to be on insulin. So when we think about medication management, we really have two options. The American College of OBGYN and the American Diabetes Association both recommend insulin first line because it doesn't cross the placenta and we don't have long-term safety data with orals. The Society of Maternal Fetal Medicine, however, came out with a position statement a couple years ago that metformin is a reasonable and safe first-line pharmacologic alternative to insulin. In the past, we've used glyburide. However, it is associated with more or higher rates of neonatal hypoglycemia, macrosomia, increased abdominal circumference in the baby, more so than insulin or metformin. And of course, and also metformin and glyburide do not have long-term safety data. So at Wake Med, we kind of adopted more of the SMFM position, and we do offer metformin to our patients, especially if they're unable to afford insulin or just very hesitant. We will offer metformin. We do have a low threshold for using insulin first. If their fasting blood sugars are well above goal, and we just feel like that their blood sugars just altogether are too sporadic and elevated, we really find that metformin is not as successful as insulin. Now, a little bit more information about how metformin works. It inhibits hepatic gluconeogenesis, inhibits intestinal glucose absorption, and stimulates glucose uptake in peripheral tissues. The big side effect and thing we always need to mention to patients when starting it is that it can cause diarrhea, nausea, upset stomach. Using the extended release, taking it with food can help with that. One of the benefits of metformin is there's no risk of hypoglycemia versus insulin, although I will say that we rarely see hypoglycemia in our pregnant patients because of all the insulin resistance of pregnancy itself. As a side note, sometimes we'll have patients in the first trimester that have been on metformin for PCOS, although that's kind of used off-label. Again, as mentioned on the previous slide, it does cross the placenta, and we don't have long-term safety data, although what we do have, that data is reassuring. And again, this statement from SMFM, it compared to insulin, they mentioned in the statement back in 2018, those moms have less weight gain, less gestational hypertension, there was less neonatal hypoglycemia, maternal hypoglycemia, It's not an injection, and it is less expensive than insulin. One of the questions that we often wonder is when we have patients that are already on metformin and then they, blood sugars aren't managed well, and what should we do with the metformin once we are going to add insulin to their regimen? That's a tricky one, and we really need more studies or ongoing studies to answer that question. We do know that there's an early study done at UNC that shows that less insulin is needed in patients also on metformin, which makes sense since metformin is increasing insulin sensitivity. And so the thing with that is there's no harm in more insulin, although I will say that if we have a patient that's requiring lots and lots of insulin, needing to split their doses in order to ensure maximum absorption of the insulin, we will add metformin for those patients just because we're uncertain how well this, multiple injections are really, how well the absorption is subcutaneously. I will, at Wake Med, we really will stop metformin if the patient isn't tolerating it or there's any signs of placental insufficiency just because of the increased risk of lactic acidosis with metformin. All right, now for insulin. Most of us have seen these insulin action curves or times comparing the really, really long acting insulins, either our 24-hour basal insulins like Largine or Detamir, our super 40-hour basal Degludec, Tresiba. We have a very rapid acting prandial insulin, Humalog and Novolog. And then we have these two older insulins, regular, that first mealtime insulin, and then NPH, a 12-hour, 4 to 8 hours at peak, 10 to 18-hour length of action. These have, historically been used a lot in pregnancy. We don't use them all that much at Wake Med. We definitely tend to use more 24-hour basals and rapid acting insulins. But some providers still will use them. I will still have some patients every now and again where their insurance just won't cover those newer insulins, and will use NPH twice daily as their basal and regular as their mealtime insulin. Now, when we think about intensive insulin therapy, just like a classic type 1 diabetic on injectable insulin, and we are looking at this white line of what happens to your blood sugar when you eat and kind of throughout the day. We're mimicking normal physiology of pancreatic function. Our pancreas secretes long-acting or basal insulin all day long, whether we eat or not. And we copy that with a long-acting basal insulin. Again, we like to use the 24-hour basals. And then when we eat, or eat carbs, we see a blood sugar spike. And so when we eat, we copy this with a rapid acting prandial or mealtime insulin at mealtime. So that's the ideal insulin replacement pattern. This is a busy slide. However, these are some important insulin rules of thumb of how we manage patients with insulin. We recommend starting insulin when we see greater than 30% of fasting or after meal blood sugars, postprandial blood sugars elevated. That's our weight-based dosing. We just, depending on the trimester, that's that amount of insulin that we'll calculate. We take that total daily dose that we calculate, like for a third trimester patient, times 0.9 units per kilogram. We take that total daily dose and half basal and half bolus, and then that bolus insulin is divided into 3 meals. We will either dose that mealtime insulin with set doses for the less savvy patient. For a patient that is motivated and able to read labels and count carbohydrate grams, we will dose the mealtime insulin by an insulin to carb ratio, just to have more specific dosing and to allow more flexibility in their diet. Again, as mentioned, we do mostly use 24-hour basals because of that long duration, the rapid acting for the rapid onset of action, just because it more closely mimics normal physiology of the pancreas. If you have to use regular mealtime insulin, it must be injected 30 minutes prior to the first bite, just because it's delayed when its onset of action is delayed. We usually dose our nighttime, our basal at nighttime, just because the first 12 hours of action, if you look at that insulin action curve, is a little bit more than the second 12 hours. If we have a patient using NPH as the basal and we've dosed it at night and you end up needing prandial insulin, remember that you must add the NPH twice a day since it's only lasting 12 hours. When we titrate insulin at WakeMed, we target the elevated trend, and then we increase the dose by 10 to 20% at a time, making sure to follow back with the patient quite regularly so that we can get our blood sugars at goal as soon as possible. And then back in the day when you need to use NPH and regular, remember that NPH insulin peaks at lunchtime if you give it in the morning. So when we use NPH BID and regular, we will dose 2/3 of the NPH in the morning and 1/3 at bedtime. And again, that we dose regular breakfast and dinner because the NPH morning dose peaks at lunch and covers lunch. That was a lot. So moving from injectable insulin and dosing, we're going to move on to insulin pumps. So this is a cartoon of what an insulin pump consists of. It is a small pancreas mimicking device that you wear under the skin through a cannula, which is a very small catheter that delivers insulin from a tube, except for one tubeless pump that I'll show you. The insulin is in this reservoir, and there's some display screen and buttons for patients to be able to deliver prandial insulin and some battery. Most patients on insulin pumps also wear a continuous glucose monitor that has a sensor that's detecting the amount of glucose in the interstitial fluid that then sends that number to a receiver, which is usually an app on a phone. With the more advanced insulin pumps that are what we call closed loop, you must have a CGM in order to communicate with the insulin pump so that you can stay in closed loop. So again, an insulin pump is a pancreas mimicking device. This cannula is worn under the skin and it provides continuous basal insulin that can either be manually set by your endocrine provider or via communication with the CGM in the more advanced models, which is called closed loop. And then when a patient eats, they will use these buttons to bolus their mealtime insulin, depending on the amount of carbs they're eating with their food. Insulin pumps are historically reserved for the most motivated type 1 diabetics. I have rarely see type 2 pregnant patients on insulin pumps. Sometimes you'll see them in elderly type 2 patients. These are the most common insulin pumps on the market in 2022. What I will tell you is that each pump set system has pros and cons to each of them. So you really need an endocrinologist and certified pump trainer to discuss those pros and cons with your patients. Both the Medtronic insulin pump and the Tandem pump do have the function to be closed loop, which I'll explain what that means in a few minutes. And the real advantage of this Omnipod insulin pump is that it is tubeless. You put the insulin in a reservoir that's in this pod. This pod is worn with the cannula, automatically injects under the skin, and it stays for 72 hours and then sends you enter your bolus insulin from another device. So you just would enter the amount of insulin you need from this separate device. That's how you bolus. The important thing to understand and advise your patients about insulin pumps is that they are very complicated syringes. So they really need to be reserved for the most motivated and compliant patients. We do not recommend starting a patient on an insulin pump during pregnancy. It takes a little bit for a patient to understand how to use them. And if they haven't used a pump before, we would recommend starting that pre-conception. Because of the increased risk of diabetic ketoacidosis with the use of rapid-acting insulin and the risk of having a pump malfunction and not really comfortable using it at that time. Now a word about closed-loop insulin pumps. They adjust basal insulin based on the continuous glucose monitor blood sugar reading. So as a patient's blood sugar rises, then the amount of basal insulin will increase, and vice versa. As their blood sugar is dropping, it will decrease and even suspend that basal insulin. The problem, of course, these pumps are revolutionary and a great advancement in diabetes technology. However, the issue in pregnancy is that they're not approved for use because the FDA regulated blood sugar targets for closed loops are higher than our pregnancy goals. And so it really just depends on the patient at WakeMed if we will use closed loop or not. We recognize that it could be difficult to use. If I have a patient that is really not doing well with manually set basals and really not compliant and not the best pump patient, I might turn on closed loop because of the ability to have that auto regulation, even though I realize that the targets are higher than our pregnancy targets. So this is something where you really just need to weigh the risk versus benefit. Insulin pump settings should be evaluated and adjusted at every visit, every 1 to 2 weeks throughout pregnancy, because just as our injectable insulin doses will increase, so will the amount of insulin that's needed in these pumps. And then many pump patients want to know, what can I do with my pump during labor and delivery? Can I keep it on? Can I wear it? Most pump patients want to. It really needs to be patient and provider specific. If the patient is not doing well and needs to be sedated, then obviously we would want to stop the insulin pump. If for some reason their blood sugars aren't stable on their pump and IV insulin is needed, then we would just remove it and start it postpartum with decreased settings because of being postpartum. Okay, so we're going to kind of move away from insulin pumps and treatment and then into our antenatal testing guidelines. So obviously our pregnant patients, their babies need to be monitored for size and the amount of amniotic fluid around the baby and in general health a little bit more regularly. These are the guidelines that we follow at WakeMed for antenatal testing. For our type 1s, we do growth scans every 4 weeks, starting at 28 weeks. We do weekly NSTs starting at 32 weeks and then twice weekly at 36. And then delivery timing is always a question for our diabetics. We deliver anywhere between 36 and 39 weeks on the earlier side if they have poor control. And then for our type 2s, we do growth scans at 32 and 36 weeks, unless there's evidence of in-organ damage, and then we would do the same as our type 1s 28 weeks, and every 4 weeks after that. We do weekly NSTs at 32, twice weekly at 36, and then for delivery timing, somewhere between 37 and 39 weeks, and on the earlier side if they have poor control. So during labor, we do recommend having operative delivery if the baby is weighing above 4,500 grams. We recommend reducing the basal insulin by half the evening before C-section, just due to the risk of hypoglycemia. Definitely, we recommend tight blood sugar control during labor with blood sugars of around 70 to 110. With these patients, we definitely want to start an insulin drip or IV insulin if their blood sugar is high. We always have to remember that our type 1s must have continuous insulin. And then so far as the delivery location, we want to have make sure that your mom is at a location where an insulin drip can be used and is available. There's enough staff to manage that, and where any neonatal hypoglycemia can also be managed. Postpartum, remember, as soon as that baby and placenta is delivered, all of that insulin resistance from those hormones are kind of removed. And so we immediately want to decrease insulin requirements by half, or to what pre-pregnancy doses. If you have the pre-pregnancy doses available, I would recommend those first. Sometimes it might be a little more insulin than half. If they were on metformin pre-pregnancy, then we could trial that pre-pregnancy metformin. And remember to remind your patient that once they've had the baby, the blood glucose goals are a little bit more relaxed. Our fasting blood sugar goals would be somewhere 80 to 120 and before meals, and then after meals, we can rise up to 160. We definitely encourage and support breastfeeding because of the decreased risk of the baby developing type 2 diabetes. So we would encourage breastfeeding. We definitely want to discuss and initiate contraception just so that they have the chance to have that preconception counseling again in case they decide they want another baby. And then we would want to coordinate follow-up with the patient's PCP or endocrinologist for ongoing diabetes management. That is it. I appreciate your time and hope you enjoyed this session on pre-gestational diabetes and pregnancy.